Surgery of Ear by Glasscock and Shambaughh. Chapter 28 Tympanoplasty, Tympanic Membrane Repair. Tympanoplasty results. Graft take and hearing results following tympanoplasty depend upon multiple factors: eustachian tube dysfunction, presence of cholesteatoma or atelectasis, previous tympanoplasty failure, lateralized tympanic membrane, and smoking are negative prognostic factors. These factors make it difficult to compare tympanoplasty results reported in the literature. However, the success rate for graft take is quite high, and overall it is more than 90%. Tympanoplasty results are summarized in table 21.8. Post-operative care. The patient is discharged on the day of surgery, or in case of uncontrolled nausea or vomiting, the patient is discharged the next morning. The master dressing and drain are removed the next day after surgery, and the patient is instructed to instill antibiotic drops in the ear canal at bedtime. Showering is allowed provided that the patient places a cotton ball impregnated with petroleum ointment in the outer ear canal. Water should be kept away from the post-auricular incision for 2 days. Nose blowing should be avoided until the tympanic membrane is healed. If sneezing is unavoidable, the mouth should be kept open. Oral antibiotics are prescribed for patients with ears that were infected at the time of surgery. The first postoperative visit is 1 week following surgery, during which the mucosal earwig, Popp's earwig, is removed. The gel foam over the graft is gently suctioned away if still present at the second visit, 3 to 4 weeks later. Persisting granulations of the ear canal are cauterized with a 25% solution of silver nitrate to promote healing. Hearing improvement may be noticed within 6 to 8 weeks following surgery. An audiogram is obtained 4 to 6 months after surgery. Post-operative instructions for patients are outlined in Appendix 1. Complications. Most tympanoplasty complications are preventable by comprehensive pre-operative planning, thorough knowledge of the temporal bone anatomy, applying meticulous surgical techniques, and close the post-operative follow-up. Patients should be informed prior to surgery regarding potential complications, and proper documentation should be made in the patient's chart. Alternate rehabilitation modalities such as conventional or the Baha system should be presented to the patient. Tympanoplasty results. Author, number of patients, technique, type of graft take, percentage, post-operative PTA and ABG. Author, Vathian at number of patients 404, overlay and underlay, temporalis fascia graft, 88% graft take, less than 25 decibel in 87% of cases. Shishi JL et al. 472 patients, overlay technique, temporalis fascia graft, 97% graft take, less than 10% decibel in 88% of cases. Glasscock ME et al. 1556, underlay technique, autologous and homologous temporalis fascia graft, 93% NA. Cuva RA, 406 patients, underlay technique, areolar tissue, 97.5% NA. Dondhofer J, 533, underlay technique, perichondrium or cartilage island flap, palisade technique, 97.6%. Pre-PTA ABG 222.8 plus or minus 12.3 decibel, post-PTA ABG 13.5 plus or minus 9.4 decibel. Aodonis L at 62, underlay technique, concha simba, cartilage shield, 98.4. Pre-PTA ABG is 32.4 plus or minus 14.1, post-PTA ABG 24 plus or minus 13.7 decibel, ABG less than 10 decibel in 86% of type 1 tympanoplasties. Intraoperative bleeding. Bleeding from accidental injury of a high and uncovered jugular bulb may occur during exploration of middle. Prompt application of a piece of gel foam soaked in saline or surgical should be able to control bleeding since the jugular bulb is in low pressure structure. In order to avoid pulmonary embolism, it is important for the packing not to be pushed into the lumen of the jugular bulb but rather to cover its surface while very gentle pressure is applied with a small moist neurosurgical cottonoid. Bleeding from the internal carotid artery can be catastrophic and should be avoided. A pulsating structure in the area of the eustachian tube orifice is suggestive of an uncovered or aberrant internal carotid artery. Facial nerve injury. It is the author's impression that during the last decade in this country, better otologic training of residents by fellowship trained faculty has resulted in a significant decrease in iatrogenic facial paralysis. The fact that the more complicated cases are referred to otologists that may have contributed to the decline as well. Post-otologic surgery facial paralysis is a devastating complication and is avoidable in the majority of cases. A facial nerve exposed in its tympanic segment is vulnerable to injury, especially if involved with cholesteatoma or granulation tissue. Jacobson's nerve and the cochleoform process are very useful anatomical landmarks for locating the facial nerve in this situation. Facial nerve monitoring, although not a substitute for anatomical identification of facial nerve, can help locate the facial nerve, guide the dissection, and confirm neural integrity. Postoperative facial paralysis is managed according to whether or not the nerve was positively identified during surgery. If the nerve was identified and not injured during the procedure, the patient may be followed with serial nerve excitability tests or electroneuronography. In the majority of such cases, the paralysis will resolve without any need for surgical intervention. When the surgeon has failed to identify the facial nerve during surgery and its integrity is questionable, exploration should be performed as soon as possible. In cases of delayed facial paralysis, the prognosis is very good and the patient can be followed with serial nerve excitability tests or electroneuronography. Reactivation of a previous varicella zoster infection has been suspected as an etiological factor in such cases. In a series of 22 patients who sustained an iatrogenic facial nerve injury, although the most common procedure performed that led to the injury was mastoidectomy in 55%, in a significant number of cases, injury occurred during the tympanoplasty part of the procedure, 14%. The most common site of injury was the tympanic segment, and 79% of patients, the injury was not detected at the time of surgery. When the facial nerve is transected more than half of its diameter, repair either with direct reanastomosis or with a cable nerve graft is recommended. For transection less than 50%, decompression is advised. No patient with direct anastomosis or cable graft repair is expected to have a better than House-Brackman grade 3 result. In the majority of cases, the greater the auricular nerve can be used as a graft, since it is located in close proximity to the surgical area and has the same diameter as the facial nerve. Facial paralysis secondary to local anesthetic always subsides within several hours following complication of surgery. Wound infection or perichondritis. These are very rare complications and present with pain, erythema, and swelling of the incision or auricle. Perichondritis can develop subsequent to the use of endoral incisions in the cartilaginous ear canal or after cartilage is harvested from the auricle for grafting. Intravenous antibiotics covering Pseudomonas and gram-positive organism can are indicated. Incision and drainage should be performed for cases with abscess formation. Meticulous surgical techniques with special attention to minimal tissue damage and frequent irrigation with saline of surgical field during surgery may prevent these complications. Wound hematoma. Hematomas form at the donor sites of graft, usually the temporalis muscle area and auricle, and present with severe pain and swelling within the first post-operative day. Good hemostasis during surgery and the routine use of rubber band drain in all tympanoplasties performed through a post-auricular approach may prevent this complication. Immediate openings of the incision and drainage is required. Chorda tympani nerve injury. Preservation of chorda tympani nerve during tympanoplasty is necessary to avoid post-operative gustatory changes. Stretching of this structure is associated with more symptoms than transection. Complete recovery has been reported in 76% of cases. Tympanoplasty candidates should be properly informed prior to the surgery regarding this potential complication. Tympanoplasty failure. Persistent or recurrent perforation, blunting of the anterior sulcus, graft lateralization, epithelial pearls develop and conductive hearing loss may require revision tympanoplasty. Poor eustachian tube function, inadequate visualization of the anterior sulcus, extensive tympanosclerosis of the tympanic membrane remnant, inadequate anterior support of the graft with gel form, previous overlay technique, and recurrent or residual cholesteatoma are common etiologies. Blunting of the anterior angle and its associated conductive hearing loss is a complication usually associated with overlay technique and may necessitate revision surgery. Meticulous technique is required during the primary procedure to avoid this complication. Epithelial pearl formation on the graft or in the ear canal is also associated with the overlay technique. Meticulous removal of all squamous epithelium from the tympanic membrane remnant and the ear canal is necessary to avoid this complication. Opening of the pearls and removal of the keratin debris can be done in the office in cooperative patients. When the graft lateralizes by migration away from the manubrium, conductive hearing occurs and revision surgery may be required. This complication may also arise when the graft is placed lateral to the manubrium at the primary surgery. Results of revision tympanoplasty are satisfactory, although slightly less successful than primary. In a recent study of revision tympanoplasty using cartilage shield technique, there was statistically significant closure of airborne gap, with the majority of cases being less than 25 decibel and the graft take was 93.5%. Most of the pure tone average PTA improvements were seen in cases with atelectatic middle ears and those with lateralized tympanic membranes. With the exception of cholesteatoma cases, significant improvement in PTA was made in all surgical groups, including those with and without mastectomy and all types of oscular reconstruction. Table 28.28-2 summarizes the revision tympanoplasty results. Recurrent or residual middle ear cholesteatoma. Recurrent and residual cholesteatomas have been reported to occur in 14% and 12% respectively of cases undergoing tympanoplasty in conjunction with ICW mastectomy. Cholesteatomas in children are more aggressive and the 3 and 5 year recurrence rates have been reported as high as 48% and 57% respectively. In another study of 199 children with cholesteatoma, in whom 215 procedures were performed, the residual cholesteatoma rate for the intact canal wall technique was 20.5% and recurrent 8.9%. For the CWD technique, the residual and recurrent cholesteatoma rates were 23.8% and 19% respectively. 88% of the procedures performed were intact canal wall technique. In 283 patients who underwent tympanoplasty with intact canal wall mastoidectomy, The incidence of residual cholesteatoma was 13.43% and recurrent 7.77%. It was more common in children 25% more than in adults 11.72% and was most frequently localized in the middle ear 47.54% than in the epitympanum 40.98% or in the mastoid 6.56%. It is evident that the long-term follow-up of cholesteatoma patients is imperative to detect recurrent and residual disease. When tympanoplasty is combined with intact canal wall mastoidectomy, a second look procedure 12 months following the initial procedure is necessary to detect residual or recurrent cholesteatoma. In the second stage procedure, the vascular strip incision can be eliminated and the middle ear can be approached directly from the post-auricular incision, avoiding a vascular strip incision provided a more stable tympanic membrane since its continuity with the posterior canal incision is not being disrupted. Ossicular reconstruction is performed at the second procedure. Revision tympanoplasty results. Author name, type of graft take, hearing results. Boni et al. Tragal cartilage, perichondrium island, concha simba palisade. 94.7% graft take, 24.6 plus or minus 13.8 decibel pre-op ABG, 12.2 plus or minus 7.3 decibel post-op ABG. Sismanis et al. Cartilage shield concave simba 93.5%, 33.6% decibel and plus or minus 13 decibel pre-operative ABG, 25.7 decibel plus or minus 11 decibel post-operative ABG, 56% of cases less than 25 decibel ABG. Moore cartilage shield fossa triangularis 100%, mean post-operative PTA 32.5 decibel, 98% of cases less than 30 decibel ABG at 2 kilohertz. Kylie et al. Temporalis fascia, tragal perichondrium 86%, 50% of PORP cases less than 20 decibel ABG, 60% of PORP cases less than 30 decibel ABG, 68% of TORP cases less than 30 decibel ABG. Degelian pressed scar tissue 91%, 21 decibel mean improvement in post ABG. Wiedelmann et al. Autologous fascia allografts 90%, 70.3% of cases less than 30 decibel ABG. Graham L at butterfly cartilage inlay graft 92%, mean pre and post ABG improvement from 23 to 21 decibel. PTA pure tone average ABG airborne gap. Sensorineural hearing loss or dizziness. This complication can be secondary to direct injury to the stapes resulting from manipulation of the structure during removal of disease. Should the stapes be partially avulsed, it should be repositioned in its original position and stabilized with a tissue graft. When cholesteatoma matrix is very adherent to the facial nerve, stapes or oval window, it can be left in place and removed at second stage procedure 1 year later. Usually at second stage, a cholesteatoma pearl is found, which is easier to remove. Other causes of sensorineural hearing loss are labyrinthine fistula, usually on the promontory, and acoustic trauma resulting from the higher speed drill contacting the ossicular chain. Although it is not absolute contraindication to remove the fistula matrix during tympanoplasty, a more conservative approach is to leave it in place and remove it at a second stage procedure 1 year later. This approach is more applicable to large fistulas that involve most of the promontory, especially if associated with infected cholesteatoma. Sensorineural hearing loss and dizziness present prior to surgery should alert the otolaryngologist to the potential of labyrinthine fistula. In such cases, a CT of the temporal bones may confirm this entity. When a labyrinthine fistula is discovered accidentally during tympanoplasty, it should be immediately covered with temporalis fascia or areolar tissue. Removal of the fistula matrix has been reported to result in severe hearing loss in 11% of cases. In such cases, post-operative dizziness may be prolonged. Thank you.